What's up, Ninja Nerds? In this video, we're going to be talking about aortic dissection. Before we get started, if you guys want to, please, down in the description box, we have a link to our website where we have comprehensive notes. We have illustrations of everything drawn on the board before and after. Everything is going to help you to solidify this topic in your brain, and you'll never forget it. All right, Ninja Nerds, if you like this video, you benefit from it, please hit that like button, comment down in the comment section, and please subscribe. Let's get into it. All right, Ninja Nerds, so let's talk about aortic dissection. First, let's focus on the causes or the etiology. So when we talk about aortic dissection, what is it? It's basically a tear through the tunica intima. You know, there's the different layers of the vessel wall. You have the tunica interna or intima, because it's intimate with the blood, right? Or then after that, you have the tunica media, then you have the tunica externa, going from the most deep to like the superficial aspect of it. Whenever you have a tear through the tunica interna or intima into the tunica media, so between the intima and the media, that is going to be a dissection. And the most common location for these dissections tend to be within the aorta. Thus the topic aortic dissection. The question is though, what in the heck causes these tears to form between the tunica intima and the media, and for blood to be able to track between those, leading to devastating effects? The first thing that we have to talk about is things that you can acquire. So things that happen that are not based upon your underlying genetics or predisposition in any way. What is that? This one I need you to remember because it is the most common cause. That is hypertension. So hypertension is going to be the most common cause of someone developing an aortic dissection. So let's put that down here, most common cause. Now generally the age range is usually someone greater than 40 to 60 years of age is the most common kind of age range where hypertension tends to be the most common cause. So greater than 40 to 60 years of age. The older generally is going to be a little bit more high risk. The other thing to think about with hypertension is that usually this is also high risk association with those who smoke, so tobacco use, and have hyperlipidemia. Having these two things associated with hypertension also severely increases the risk of aortic dissections. Now the question is, and this is what we have to be thinking about, how does hypertension lead to dissections within the vessel wall, particularly the aorta? What does it do? Well, it's kind of simple, right? One of the things that you can think about is it's just sheer stress. So if we have blood that's flowing through this vessel, let's say here's blood flowing through this vessel, right? The higher pressure that the blood is actually flowing through this vessel, it's able to exhibit kind of like shear forces on that vessel wall. Maybe enough to tear, create like a little tear through the intimal vessel lining. And if it just creates enough of a little tear there, blood can start tracking in between the tunica intima and the tunica media. So that's one mechanism, right? So one of the mechanisms by which that can happen is, we can say it could be by just shear forces causing little tears within the vessel wall. The second cause, and this seems to be another one that's very interesting. Let's find a little pretty color here, a little blue. You know vessels? There's a term called vasa vasorum, vessels on vessels. There's tiny little blood vessels that love to serve the tunica media and the tunica externa. Because you know the tunica intima, it gets its blood supply straight from the source, the blood from the lumen. But the tunica media and the externa, they got to get their blood from somebody else. They get their blood from this structure here called the vasa vasorum. It's a pretty cool name. What happens is that somebody who has hypertension can lead to arteriosclerosis. You know that hyaline arteriosclerosis? It can basically kind of make the blood vessel a little bit thicker and the blood's not flowing as well through those little bad boys. If blood isn't flowing as well through these vessels, the vasa vasorum, are you able to get enough blood flow to the tunica media? No. So there's decreased blood flow to the tunica media. It starts kind of dying off. If the tunica media starts dying off and undergoing necrotic types of processes, is it going to be able to function to allow for good resiliency or strength of the vessel? No. Now the vessel wall becomes weak, susceptible to now having a tear and then leading to a dissection. So the other mechanism is some type of arteriosclerosis of the vasa vasorum. Such a cool name. But these are the two things that I want you guys to remember as potential triggers for the aortic dissection that's from hypertension. And again, biggest thing, I want you guys, if there's any other etiology that you guys forget, please do not forget this one, hypertension. Okay, boom, shakalaka. Let's move on to the next one. The next type of cause here is trauma, and there's really nothing to go crazy or ham on this one. It's usually just, it's a simple cause. Trauma is enough that maybe it's a acceleration, deceleration injury, and that's enough to just create a tear within the actual vessel wall and blood to track between that intima and media lining. So trauma tends to be another type of cause that can be acquired. And again, that traumatic cause could be due to, look at this, you got two like Toyota Tacomas just going head to head, bop, bop, bop. That could be a potential trigger. So some type of motor vehicle collision. And usually when there's tears within the vessel walls due to some type of motor vehicle collision, it's usually secondary to some type of deceleration kind of injury, right? So that is something that we have to think about. The other type of trauma is something that you might not be thinking about, but it actually could be due to someone actually going in and kind of just, maybe they're trying to go in and do some type of surgical procedure. And when they're going in and doing a surgical procedure, they just so happen to nick or tear or cause some type of iatrogenic injury to the aorta. That's something that you have to think about. So, what is another potential trigger that you have to think about? Not just motor vehicle collisions with trauma, but some type of iatrogenic cause. And these are usually, like, for example, someone has, for example, they have a MI, and you're going to be threading a catheter in there during the percutaneous intervention, and you're threading a catheter to try to get into the coronary vessels, and when you do that, you just happen to tear through the aortic wall. So that could be one potential reason. It could be that you're trying to do some type of catheterization. So maybe when you were doing some catheterization, you just accidentally caused a little tear within one of the coronary vessels. Sometimes it could be if you're actually going in to repair a valve. So sometimes if you're doing like an aortic valve repair and maybe you're doing that through some type of endovascular process or open process, there's also the potential that you can create a little dissection. So sometimes it can be from certain types of valve repairs. Okay, but I don't want you guys to harp too much on these. I want you guys to focus mainly on hypertension and just remember that trauma is another potential cause, and it could be from actual motor vehicle collisions or it could be an iatrogenic trauma from surgical procedures, okay, or some type of intervention. All right, the next one. This one's actually starting to gain some more headway, actually, and it's something that I want you guys to definitely be thinking about. So I want you to basically really remember hypertension. Think about trauma, but the third one that I want you guys to not forget about is vasculitis. Vasculitis is definitely very interesting. So what the heck is vasculitis? So vasculitis is inflammation of the blood vessels. So there's inflammation of the blood vessel wall. Now, the particular triggers for the vasculitis could be what? It could be a bunch of different things. You know, see how I just caught that marker there? That's how good we are here at Engineering. So vasculitis, it could be something like syphilis. You know, syphilis, there's tertiary syphilis. So particularly tertiary syphilis. And tertiary syphilis, it goes back to that little structure back there called the vasa vasorum. So what it can do is it can take the vasa vasorum and cause inflammation of the vasa vasorum. So it loves to cause the Treponema pallidum, which is the bacteria. It likes to cause inflammation and deterioration of this actual vasa vasorum. If you cause kind of the deterioration of the vasa vasorum, then you start altering the blood supply to the tunica media, and that can lead to cystic medial degeneration of that tunica media, weakening the wall, therefore predisposing it to some type of dissection. So again, it goes back to syphilis leading to some type of inflammation of the vasa vasorum. And then this can then lead to what's called cystic medial degeneration. And that's particularly of the tunica media, okay? Another one to think about associated with vasculitis, this one comes up sometimes, not super common, but what's called Takayasu's arteritis. So this is a medium vessel vasculitis. And what happens is, in these patients, they actually develop what's called granulomas, inflammatory granulomas that kind of get deposited within the vessel wall. And these inflammatory granulomas, they basically cause a lot of inflammation. That inflammation over time can start to cause degeneration, some media degeneration of the actual tunica media, weakening the vessel wall, making it more predisposed for a quick, easy tear if there's an acute rise in blood pressure, okay? So Takayasu's arteritis. Think about inflammatory granulomas. Another big thing to think about here is that there is another condition that sometimes this can kind of look like, and that is giant cell arteritis. Giant cell arteritis, though, tends to be in people greater than like 50 years of age. Takayasu's arteritis tends to be in patients usually less than 50 years of age. So another thing to think about is you think about patients less than 50 years of age, okay? And usually Takayasu's primarily is going to involve structures like the aorta, okay, aortic arch, some of the branches off of it. But giant cell, it likes to involve kind of like your temporal vessels, your external carotid vessels as well. So you don't get as much of the facial involvement, the ocular involvement with Takayasu's, okay, in comparison to giant cell arteritis. There's other kinds of vasculitides to be thinking about. I don't want us to go too crazy on them. I just want you guys to remember these two because they're big, high yield for your exams, okay? So that covers our acquired causes. Let's talk about the congenital causes. There's another thing that you guys need to know for hypertension. Okay, because this definitely can come up on the exams. When we talk about hypertension, we all the time, associated with hyperlipidemia or smoking and things like that, or maybe just underlying kind of congenital causes of essential hypertension. But another big thing is if someone has a brief rise in hypertension due to some pathomimetic effect. This will show up on your exams potentially. So I want you guys to really quickly for a second, we'll come back to congenital here, but hypertension could be secondary to something like cocaine or amphetamines of some type. Okay, so please don't forget that. And sometimes in your exams, you may even get like they were working out and they were lifting really, really heavy weights and they had a heavy Valsalva maneuver and that was enough to cause a brief rise in blood pressure. But these are big things to remember because these may be contributing to the hypertension and cause the aortic dissection. So please don't forget those, okay? All right, so now let's get into the congenital causes of aortic dissections. Now, when we think about these, the actually relatively easy one to think about for most of these, the first one is connective tissue disorders. So again, I want you to remember hypertension for the acquired, that's the most important one. And then over here for the congenital causes, I don't want you to forget the connective tissue disorders. And these are actually not too bad to like conceptualize how they cause dissections. It's not too hard because they're a defect within some of the connective tissue lining of the blood vessel. And there's tons of connective tissue within the blood vessel. The subendothelial lining, the elastic lamina, the tunica externa, there's tons of connective tissue within the vessel wall. And if you have defects within the proteins that make up the connective tissue, you weaken the vessel wall, you make it susceptible to tearing the actual endothelial lining or creating aneurysms, and we'll talk about that in a second, therefore increasing susceptibility of dissections. So either way, it's a relatively easy concept to understand. So don't forget hypertension and don't forget these two connective tissue disorders. The first one that I want you guys to remember is Marfan syndrome. Okay, so Marfan syndrome, think about these in like individuals who are really tall, they have long arms, they got really long fingers, arachnodactyly, they have like hypermobile joints, and they maybe even have like some lens dislocation and they have cardiovascular issues, right? But the big thing that I want you to remember is how do they lead to the connective tissue disorder or defect? They have a mutation in the gene that synthesizes or leads to the translation of a protein called fibrillin. Now, fibrillin is a protein that is good for a lot of your elastic lamina, provides a good amount of elasticity to the vessel. If you have a defect in this and you have a decrease or mutation in the fibrillin gene, you then decrease your elasticity. And if you decrease the elasticity of the vessel wall, what is the problematic issue with that? Well, you can lead to what's called aneurysms, and aneurysms can potentially precede or predispose a person to a dissection. That's a worthy conversation real quick. Let's write that down. So aneurysms, right? What are aneurysms? Aneurysms are basically ballooning of the actual vessel wall, right? When you have ballooning of the vessel wall because of maybe a decrease in elasticity or some other disorder, when you have ballooning, it's really easy. Those vessels are really thin because they're stretched. It's easy for you to really dissect and break through the intimal lining and in between the intima and the media. And so aneurysms can predispose a person or put them at high risk for developing dissections. But guess what? In the same way, if someone develops an aortic dissection, the blood can track through the intima and media lining, lead to maybe some ballooning out of the actual vessel, leading to aneurysms or pseudoaneurysms really, but predispose a person to actually developing rupture. So these are kind of a dynamic back and forth kind of interaction here. Big thing to think about. But the main one I want us to kind of associate this with is aneurysms going into dissections. That is the big thing to think of. So Marfan syndrome is predisposed to aneurysms and dissections. What else? Let's get back to this. The other one is Ehlers-Danlos syndrome. We're going to abbreviate that as EDS, Ehlers-Danlos syndrome. This is also something you want to think about in patients particularly who have like hyperextensible, hypermobile joints, hyperextensible skin, easy bleeding. They bleed very easily or bruise easily, and have cardiovascular disorders like aneurysms and dissections. But their particular issue is they have a mutation within the genes that transcribes and translates collagen. And so if there is a mutation or a defect or a decrease in the collagen production, collagen is important for the resiliency of the blood vessel. And if we don't have good resiliency or the ability to resist high tension or high blood pressure forces, it's easy for that actual vessel to be predisposed to tearing, creating an actual intimal flap, and then causing dissections or aneurysms. Okay, so that's a big thing to remember, is that they can have decreased resiliency. Okay, beautiful. That covers our connective tissue disorders. So again, hypertension, most common, but I want you to think about these because these will probably show up on your exam. Okay? Next one is a bicuspid aortic valve. This is again becoming a big kind of one to think about. So bicuspid aortic valve, what the heck is that? You're like, I don't know I thought they had 3 valves, man. They do. So bicuspid aortic valves. We're going to abbreviate aortic valve, AOV. So bicuspid aortic valves. You know what these are? Generally, you should have 3 cusps. That's why the semilunar valve, there's 3 of these cusps. In a bicuspid aortic valve, there's a kind of a genetic kind of issue here where 2 of these kind of 3 valve cusps fuse together and create this bicuspid valve. The problem with bicuspid aortic valves is a couple issues. One is it predisposes, there's an increased risk of developing aortic kind of valve issues, particularly what's called aortic stenosis, and less commonly aortic regurgitation. Okay, so more commonly you'll see the aortic stenosis, and less commonly you'll see the aortic regurgitation. You know what else? If you have someone who develops aortic stenosis, what does that do to the left ventricle? It puts the left ventricle under a lot of stress. It's got to work harder. It's got to pump more blood out of the ventricle against this kind of stenotic valve that's not opening very well into the aorta. That can increase the risk of hypertension. And they can have high blood pressure. What was one of the particular risk factors or triggers for aortic dissections? Hypertension. So now you have a person who has an aortic stenotic valve or potentially an aortic regurgitant valve. Now you have them having some high blood pressure because of this bicuspid aortic valve. Guess what? Through a mechanism, and I'm sorry, I tried to look everywhere, through a mechanism we just don't have an exact answer for. There is increased risk. It may be because of the hypertension that this happens, but there's an increased risk of aortic aneurysms, and Therefore, by way of that interaction we just talked about above, increase risk of aortic dissections. Again, not quite sure how this aortic aneurysms happen. It may be because of something going on with the aortic valve, causing aortic root dilation. It may be because of the hypertension. There may be an underlying mechanism we just don't know. But that's something to think about. So now, if we come down here for a second, look at how this could happen. If you take someone who had this now bicuspid aortic valve, you cause their left ventricle to get thicker, so now you kind of cause like a left ventricular hypertrophy, leading to a hypertension. That causes this left ventricle to have to work harder. If it has to work harder and push more blood out, that hypertension may cause stress on the actual aorta, leading to it to cause dilation, aneurysms, and then just enough to create a false lumen and lead to a dissection. Okay, so that is something to think about as a potential cause as well. So we got big one, hypertension. Second one I want you to remember is connective tissue disorders. The third one I want you to remember is bicuspid aortic valves. Okay, what's the last thing that I want you guys to remember? The last one that I want you guys to remember is what is called, let's find another color here, let's just go back to black. This is what's called a coarctation of the aorta. So we have what's called a coarctation of the aorta. You're like, what that mean, man? All right, so it's basically a narrowing or a very, very narrow area of the part of the aorta. Where? Usually there's a narrowing of the aorta at a very specific point. It's usually after the aortic arch. So generally we say it's near like the left subclavian artery or near like wherever the ductus arteriosus is. That's usually where it's found. So there's what's called a narrow aorta at the level of the left subclavian or nearby ductus arteriosus, okay? What's the problem with that? If you have a narrowing of that vessel, okay, the aorta after the left subclavian or near the ductus arteriosus, when you pump blood out of the left ventricle into the aorta, it now has to squeeze through that tiny little area. That's a lot of resistance. And so what's going to happen is the pressure proximal to wherever that occlusion is or that narrowing is, it's going to cause the blood pressure to start to rise proximal to that. And so this is going to lead to hypertension as a result of that narrowing or coarctation of the aorta. That hypertension can then lead to aneurysms, or it may lead to a dissection or aneurysms back and forth between the dissection, right? So it's one or the other. So you get how that can become a problem. A big thing to think about here for this one, and it's actually really interesting, is that patients who have coarctation of the aortas, usually there is a very particular disease that they'll probably present this on the exam for, is they have a history of Turner's syndrome. So Turner syndrome. And guess what? They probably also have, there's a high likelihood that they have a bicuspid aortic valve associated with it. So these are big things to think about for your exam, okay? So we've covered all the causes. The ones that I want to put the most stress on though, hypertension, connective tissue disorders, bicuspid aortic valve, and don't forget coarctation of the aorta. Less common ones I'm not super concerned with is trauma, and then on the end of it is your vasculitides like syphilis, Takayasu's, and other ones. Let's now start talking about the pathophys. All right, Ninja Nerds, so we finished up causes and etiology. Let's now talk about pathophys, right? So the pathophys should be a branch. It should be telling us how the causes led to the dissection, how those dissections of a person's vessels, particularly the aorta, and how that propagates, leads to clinical manifestations or features. That should be the bridge. So let's talk about that. So we know the causes. So what happens is any of these causes that we just talked about, let's say we have blood flowing through this vessel here, okay? If we have blood flowing through this vessel, it's like, it's surging through this vessel. As it surges through this vessel, and for some reason there's a tear within the intimal lining. Here's our tear. If it tears, what can happen is blood can still flow down what's called the true lumen. So this is what's called our true lumen, okay? Or it can then move in between that intimal flap and then start propagating down this way and this way between the intima and the media. That's kind of how this whole issue happens. Now, what can happen from here is three particular things can happen. You can get lucky And some of the blood within that dissection can move down between the intima and the media and then back through another intimal flap somewhere, back into the actual true lumen. Not always going to happen, but it's possible. The worst case scenario is that you create enough of that hematoma expansion, the vessel's really, really weak, and you cause rupturing of the actual vessel wall, okay? So it's enough for the blood flowing through that actual false lumen to create a rupture as a result, okay? So one of the devastating effects is some type of rupture of this actual vessel wall, okay? The second thing that can happen here, so we have the first one is you can actually enter back into the true lumen. You can actually cause a rupture. What's the third thing that can happen? The third thing that can happen is it can track down, again, between the intima and the media. And let's see here you have a branching vessel. So here's what's called a branching blood vessel. Maybe this is going to the kidney. Maybe it's going to the heart. Maybe it's going to the spleen. Who knows? It's going somewhere. And the blood that is tracking between the intima and the media in that false lumen decides, hey, I'm going to go over here and start clamping down. I'm going to have all of this blood kind of start, forming a hematoma that starts kind of occluding on this branching vessel. And now look what happens as a result. You start getting narrowing or almost a complete worst case scenario occlusion of that branching vessel. So what's the potential that can happen with that? If you have that issue there, you can then develop a occlusion. So worst case scenario is you develop an occlusion or narrowing of that branching blood vessel. So three things can happen from a dissection. One is it can tear through the intimal lining, track down between the media and the intima through that false lumen, and then back into the blood vessel wall if there's another intimal flap. Or it can create enough pressure that it ruptures the vessel wall, or it can track down through the false lumen and then compress, cause a dynamic obstruction on a branching blood vessel, leading to occlusion of that vessel. And this is a big one that we'll focus on a lot down here, leading to particularly what's called malperfusion syndromes. Malperfusion syndromes. And there is tons of these that we have to focus on. The last thing that can happen is, let's actually say here we have another intimal flap. Okay, another intimal flap here where you tore through by one of these causes, and blood starts kind of tracking through here like it normally does. But when it does, it actually forms like, your false lumen with a hematoma within it. Sometimes it can form a hematoma right where the intimal flap is, that the actual hematoma can actually start expanding into the lumen. And you can get what's called an intramural hematoma associated with this. So another potential complication, just to have, why not, is an intramural or like luminal, some type of thrombus that actually forms there. So there's a couple things that can happen, okay? So we'll number them. One is it can come back into the lumen via this other intimal flap. Two is you can cause a rupture. Three is you can lead to an occlusion of a branching vessel, leading to a malperfusion syndrome. And four is you can lead to an intramural or intraluminal thrombus. These are some problematic issues. Now, how do these problematic issues, particularly focusing on this one, how do they cause particular symptoms, clinical features, complications? I'm glad you asked. Let's go ahead and take here, we have a diagram. Here's our aorta. So you have your ascending aorta right here. Then you're going into the aortic arch, which has your branching vessels here. Then we come down through the descending aorta down into the iliacs, right? What happens if we develop a malperfusion syndrome that affects vessels? I'm just going to use this blue to kind of represent, here's where that false lumen, the hematoma is starting to press on these vessels. Let's say here that this is a coronary vessel, right? So if this clamps down on one of your coronary vessels, what can that do? Oh no, man. You can end up with an MI, right? You can squeeze down like a right coronary artery, which is the most common one, and this can lead to a acute coronary syndrome, with worst case leading to a MI, like a STEMI, InSTEMI, something of that nature. You know what's even worse and scarier though? What if it starts tracking through that actual false lumen through the branching vessel, and it actually ruptures. And when it ruptures into a space that's actually kind of surrounding the heart. You know, for example, let's say here in purple here, here's your coronary vessel. It usually tracks along the epicardium, right? And then what it does is it gives little branches that, you know, penetrate down into the myocardium. If you dissect that purple vessel and then enough of it ruptures, where could it rupture to? Right into your pericardium. If it ruptures into your pericardium and you start getting blood that accumulates into your pericardium, what is that called when you have blood within the pericardium? A hemopericardium. And what if that hemopericardium becomes so significant that it starts compressing on the ventricles and doesn't give the ventricle enough ability to contract and get blood out of the heart? And it causes low blood pressure. It causes jugular venous distension. It causes distant heart sounds via Beck's triad. Cardiac tamponade. So another potential complication here is you can develop what's called tamponade. So please don't forget these things, okay? You can develop an acute coronary syndrome, you can develop cardiac tamponade. One other thing, okay? Let's say that the dissection, let's go back to our blue color here. The dissection not only tracks, you know, down the coronary vessel, ends up dissecting through the coronary vessel and end up rupturing. Let's say that it actually tracks downwards, more down the ascending aorta and into these little things here that we call your leaflets, your valve flaps. What if it kind of dissects down into that? Well, look here. Let's say we kind of zoom in. Let's say here's the intraluminal, here's the actual intimal flap. Blood goes here, blood goes here. It starts tracking down, and then it tracks right into the valve leaflet. If it tracks into the valve leaflet, what can happen as a result of that? It can cause the valve leaflet to stop working. And then guess what? If blood kind of starts accumulating into that, it can start maybe sagging down. And if it sags down, is this good at being able to prevent backflow into the left ventricle? If you actually contract the heart, blood will go out. But do you have something to block it from coming back in? No. So another huge clue is if you have this on the exam where you have somebody who presents with symptoms that we'll talk about in a second of an aortic dissection and a new aortic regurgitation murmur on auscultation, that's something to be thinking about. Please don't forget that. Okay, boom shakalaka, let's move on to the next thing. The next thing is, let's say that you develop some type of, again, dissection, and it starts actually propagating and causing some occlusion of the vessels that are coming off of the aortic arch, all right? So it's starting to come off of the aortic arch. You know, you have your internal carotid arteries. You know, for example, here, this vessel here is called your brachiocephalic. The first one that comes off, and the brachiocephalic splits into the right subclavian and right common carotid. The second one is the left common carotid, and the third one is the left subclavian. If you develop a dissection that then propagates its way into and causes an obstruction of these vessels, your common carotids. So now your common carotids will give way to your internal carotids, which will supply the brain. If you have decreased flow to the brain because you have a dynamic obstruction from a dissection, what's going to happen? You can develop a stroke. Sometimes you may develop first signs of syncope, right, because you're getting less perfusion to the brain. But then if it happens over a long period of time, there's no treatment, there's no reversal, you can eventually lead to a cerebrovascular accident, like an ischemic stroke. Okay, so that's something to really, really be thinking about that you can actually have with this issue here. The next one, all right, you know, I've been working out a little bit, so I've been getting some muscles, you know, and I got a tattoo of my best friend Rob on there, you know, it's just the way it is. But let's say that I had an aortic dissection going into my tumorous muscles here, okay? And you know the left subclavian, right? So this is our left subclavian. Let's say that that's going to go and supply the left upper extremity, my massive left upper extremity. You know, Rob tried to put his name on it to pretend like it was his arm. It's my arm. I just got Rob's name on it as a tattoo. But let's say that I have this left subclavian supplying the left upper extremity. And let's just say you end up getting a dissection that propagates over and causes an occlusion or dynamic obstruction of the left, we'll put left subclavian artery, okay? If that happens, and blood is supposed to be coming through the ascending aorta, through the aortic arch, it'll go down here and give off blood to go to the left subclavian. Or it should also go here via the right subclavian. Let's say that there's no dissection near the area of the right subclavian artery, but there is a dissection that's propagating around the left subclavian artery. So there's occlusion or dynamic obstruction of the left subclavian, no occlusion, no dynamic obstruction of the right subclavian. What's going to happen if I go and check the pulses on their left upper extremity and compare to the pulses on the right upper extremity? I'm going to have decreased pulses on this side. So as a result, one of the big telltale signs on your exams is that you have decreased pulses on this, in this case, the left upper extremity. Usually that's one thing. The second thing is if I take a blood pressure. If I take a blood pressure using a cuff or an arterial line on that left upper extremity and I compare it to the blood pressure using a cuff or an arterial line on the right upper extremity, what's going to be the differences in my blood pressure? Well, the blood pressure is going to be lower on this side and it's going to be higher on that side because I have something that's obstructing blood flow. So as a result, there could be lower blood pressures on the left upper extremity. Sometimes we say greater than 20 millimeters of mercury for your exams, okay? Another consequence of this is that what if it's really bad and I'm decreasing blood flow to the muscles in the arm? Then I can start causing maybe an acute limb ischemia. So I may start losing color. I may start having pain. I may start having decreased pulses. The muscles actually may start becoming like weak and potentially causing like a little bit of weakness or paralysis. They start becoming cold, poikilotherma. So those are also things to potentially think about that can happen in this scenario. Okay, what else? Okay, let's move down. We move down to the next part. Let's say that we have a dissection that's continuously propagating. And there's two types of dissections we'll talk about in a second. But let's say that it's moving down here and it decides to dissect through this part and then down and cause kind of a dynamic obstruction or malperfusion syndrome to this organ here in the abdomen. And now you got decreased blood flow going to the kidney. What does the kidney do for us? Makes urine, right? If you got decreased blood flow going to the kidney because of this malperfusion effect, what's going to happen? You're going to have a low urine output, right? And then the problem with that is that if you don't get rid of particular types of metabolic waste products, what's going to happen as a result of that? You can develop something called a acute kidney injury because you're not getting enough blood flow. So some of the actual kidney tubular cells will stop functioning very well. You're also not going to be able to make urine because you have less volume going to it. And this can cause an increase in your creatinine, and this can cause an increase in your BUN as well as a result. And that's kind of a sign of an increased injury or acute kidney injury. And another thing is maybe you'd have a drop in your glomerular filtration rate as well. Okay, so you're filtering less of the actual less filtrates coming to the kidney, and you're just not filtering enough of it because you have a low blood volume coming to it. Okay, so acute kidney injury is a thing to think about. Let's say again, you have blood continuously flowing down. You dissect through, okay, this intimal flap, and it dissects, and starts causing a dynamic obstruction of the artery of Adamkiewicz. Okay, and then less blood flow is going via this anterior spinal artery, and so you're not able to supply almost the entire anterior 2/3 of the spinal cord. What can happen as a result of this? You can get something called anterior spinal artery syndrome, which could then affect your anterior gray horns, so you can start developing weakness, right? Potentially maybe paraplegia, right? So paraplegia particularly affecting, since this usually happens in the lower extremities, you're going to develop paraplegia of the lower extremities. You may have loss of sensations, and maybe even incontinence, and potentially incontinence. So these are things to think about as well. Okay, let's say that we keep going. We actually continue to have blood flow moving down, dissects through here, this intimal flap, continues to propagate, and then causes a dynamic obstruction of one of the vessels. Maybe it's the superior mesenteric artery. Maybe it's the inferior mesenteric artery. Maybe it's the celiac trunk, something of that nature, but it's occluding blood flow that's going to parts of your GI tract. Usually, like superior mesenteric artery is a big one to think about. But if you have decreased flow that's going to your GI tract, what can happen as a result of that? Particularly if it's like small bowel, you may get something called like an acute, like if it's affecting like your superior mesenteric artery, you may get something like an acute mesenteric ischemia, where there's less blood that's actually supplying the oxygen to the tissue cells of the enterocytes and different parts of the GI wall. And so this can lead to intense abdominal pain, right? So obviously as a result of this, you'll have someone with abdominal pain. What else? Not only could you have abdominal pain, but you also could have something like bloody diarrhea. So you can have bloody diarrhea if the actual bowel wall infarcts. And then maybe even symptoms potentially if the bowel wall infarcts and you're not able to get enough motility through, you can even have like nausea, vomiting, abdominal distension in the later stages. So things to think about there, okay? All right, what if we continue down, man? It's like it's never ending, right? The blood vessels continuing to propagate down maybe another intimal flap. As it propagates down the intimal flap, it then starts affecting the blood flow through maybe an iliac vessel, maybe like an aortoiliac disease, right? And if you have blood flow, let's say going down to the left, right? The left lower extremity. So here, let's say that there's normal, no issues with dissection going down the right lower extremity, but there is a propagation of the actual dissection moving down to the left lower extremity. Now this is Rob's leg because he doesn't follow leg day, okay? So he usually, this is his leg, that's my arm, that's Rob's leg, okay? He skips leg day, all right? So we have left lower extremity here that's getting less blood flow. If there is less blood flow, what's gonna happen? If you check the pulses in the dorsal tibial, or you check the pulses in the, in the actual dorsalis pedis or near the medial malleolus, what's gonna happen to the pulses there? Well, you're going to have less pulsing down into this area. So you may have decreased pulses of the left lower extremity, If you were, let's just say, you were to take a blood pressure, there's no particular reason, but let's say that you had like a femoral arterial line, and that was the way that you were measuring like blood pressure. If you checked femoral arterial line or you had like a cuff around their thigh for some reason, what would happen to the blood pressure differences in the left lower extremity in comparison to the right lower extremity? You would have lower blood pressure, okay, of the left lower extremity. And then again, if there's not a lot of blood flow flowing through that left lower extremity, you can develop an acute limb ischemia, where again, it can have less color, so it can have pallor, you can have pain, you can have less ability to control the temperature, so it's going to be cold, poikilotherma, paralysis, decreased pulses, the whole 9 yards, and this is something that can be very, very, very problematic, okay? So that's this is all of the particular things that I want you to think about that are complications and some potential symptoms or clinical features of someone coming in with an acute aortic dissection. All right, so now let's talk about the diagnosis of someone with an aortic dissection. We know our causes and our etiology and triggers. We know how these things can present basically via the pathophysiology. Now it comes down to the diagnostics. We got everything. We're trying to say, okay, what could be potentially going on? There's one more thing that we didn't talk about, and I know you guys are probably like, where's this? I thought that this is like one of the key things. Don't worry, it's here. Diagnosis also involves your history and your physical exam. This is a big, big thing. So if someone comes in and they complain of a ripping, tearing type of pain, and you have it localized to 3 particular areas, that's also a common kind of diagnostic clue of someone with an aortic dissection, along with all of these other things that we talked about. So if they present with a tearing, ripping pain, that's like an anterior chest pain. This is what I want you guys to associate that with. Anterior tearing, ripping chest pain usually is associated with the ascending aorta. So there is some type of dissection involving the ascending aorta. All right, sorry guys, I keep losing my marker. It happened before. All right, but anyway, if we have someone coming in with a tearing, ripping pain and it's located in the anterior chest, like that's involved, we can have a high suspicion that it's involving the ascending aorta. It may be propagating beyond that, but it definitely involves the ascending aorta. The next one is if we have a tearing, ripping pain that maybe involves the anterior chest, but it kind of radiates into the neck and jaw pain. You want to think about a dissection that's potentially involving aspects of the aortic arch and maybe branches of the aortic arch, such as like the carotids, potentially it being involved in some way, shape, or form. Okay? If you have a tearing, ripping pain that's starting to involve between the scapula, so you have what's called an interscapular pain. that may mean that the actual descending aorta, maybe beyond the aspect of the brachiocephalic, the left subclavian artery is starting to be involved. So potentially the descending aorta is starting to become involved here, okay? So these are things to think about. If a patient comes in with ripping, tearing pain in the anterior chest, ascending aorta could be involved. If it's involving the neck and the jaw, the aortic arch and some of its branches can be involved. If it's going back into the scapula, in between the scapula, the descending aorta can be involved. So these are things to be thinking about. Now, the most common location for someone to develop an aortic dissection is actually the ascending aorta. So this is usually the most common location is going to be the ascending aorta, usually like 2.2 centimeters from the aortic valve is usually where you're going to get that involvement. All right, we have the clinical features that are highly suggestive of it. What kind of test do we want? We can get an EKG. An EKG is not really it's not going to tell us that there's an aortic dissection. It's giving us an idea if there's a potential complication associated with aortic dissection, as well as ruling out other causes of chest pain. Anytime someone presents with chest pain, they got to get an EKG, right? So it's designed to be able to rule out an acute MI. Now here is the problem. What was one of the malperfusion syndromes that you can have in someone with an aortic dissection? If it involves that coronary area, you can have a patient present with, it's possible that they may have ST segment elevation. It's possible that they may have ST segment depression. So these are things to consider if they present with that. They may have signs of an acute MI, but it may not be due to the classical cases of like a plaque or some other issues like that. It could be due to a dissection. And so that's something to be thinking about. When you get EKGs, it's also important to correlate these with your troponins. And so if you get troponins, it's possible that they may be positive as well. Okay, but again, that's not telling you that the aortic dissection is causing an MI. It could be due to that via the malperfusion syndrome. Get an EKG, anybody sometimes has chest pain, okay? What's another test that we can get? We can get a chest x-ray. They're quick. You have a patient coming in to the ED, they're presenting with these pains, or they're somewhere in the hospital, you get a quick portable chest x-ray. It's a quick thing. Why? Because if someone has chest pain, you want to differentiate, is there other things that could be causing that chest pain? So a big thing to do with this is maybe it helps to rule out like a pneumothorax. Maybe it helps to rule out like a pleural effusion. Maybe it helps to rule out like a pneumonia. But what could it tell us that maybe helps us think about aortic dissection? This is high yield. Let's make it pink to make it pop, right? So this is a wide mediastinum. So there's a widening of the mediastinum. Now, how wide does that sucker have to be? It's got to be about greater than 8 centimeters. So when you're measuring the mediastinum, if you get a mediastinum that is greater than 8 centimeters, that is suspicious for an aortic dissection. It is not diagnostic. I had someone who told me once that a chest x-ray is kind of like a poor man's angiogram. It can give you an idea that they could have an aortic dissection, but you may need further imaging. Okay, so a widened mediastinum greater than 8 centimeters, this is a high yield thing to remember for your exams. Okay, we got EKG correlating with the troponins. We got a chest x-ray to help us rule out other things that could be the cause of the chest pain. We see a widened mediastinum greater than 8 centimeters. What else could we do? Other things that you can do is a TEE. Now, this is not always the first thing that you're going to do. It's something that you would do. What is it? Oh, first off, what the heck is a TEE? I'm sorry. It's a transesophageal echocardiogram. You take a probe, an echo probe, you put it down through the esophagus, and it gives you a good view of the aorta, okay? You can do a TEE in patients who are hemodynamically unstable. So this is kind of preferred when you have a patient who's hemodynamically unstable. If a person is super hypotensive, they're not able to protect their airway, they have pulmonary edema, usually it's just if they're really, really like hypotensive in some way and they're at risk of crashing or they need to go to surgery immediately, you're not going to send them to get a CT because that takes time. There's a lot of risk in that. So sometimes you can do a bedside TEE without really a lot of sedation and analgesia to get that done. And what that could tell us, another reason you could do a TEE is if they have severe and I mean really, really bad. This shouldn't alter you from getting that test, but if they have a really, really, really bad GFR where they're at risk for a contrast-induced nephropathy from the radiocontrast dye, CIN, contrast-induced nephropathy, that could be another potential region, but it shouldn't alter you from getting a test that you absolutely need, but do think about that for your exams. TEE, what could it tell us? If you get a good enough view, you may be able to pick up like an intimal flap. So where that flap is that had the rupture, you may be able to pick up like a false lumen. And you know what else is really good about getting a TEE? What did we say were one of the complications of the heart? You can get a cardiac tamponade. So it can also rule out, see if there is or not a tamponade present, because that is important. That is a very significant emergency that needs to be intervened on immediately, okay? Because that may be the reason for their instability, okay? So good things to get there with the TEE. And again, this can be done bedside. So that's why it's a little bit better for unstable patients, but you shouldn't delay what the definitive or kind of like gold standard test is. The gold standard, and I'm gonna write that down here for you guys. This is your gold standard. They like to use that a lot in the, your exams. So the gold standard test is your CT angiogram. Another option, we'll write it down. You probably don't always need it. We'll write it over here on the side, is you have something that's synonymous to this. It's just a little bit different. You can do what's called an MRA. It's an MRI angiogram. A CT angiogram is completely fine. You would get an MR angiogram if they had like a severe contrast problem, like a contraindication to getting a CTA. But MRAs take a long time, and that's not great. You usually would have to be hemodynamically stable to do that. Either way, gold standard is the CT angiogram or the MRA, and this is usually for hemodynamically stable patients. It's also going to tell us a little bit about their anatomy, which can help with surgery. So whenever the surgeon looks at that, they have an idea of where they need to enter, how it's going to help them within their surgical process, okay? And again, what could it tell us? It could show us the intimal flap. Same thing as the TEE. It could tell us the intimal flap. It could show us if there's any false lumen. You know what else it could show us? It could show us if there's a rupture, or there's a leak, or there's extravasation. So it could show us if there is some type of rupture or leak. And another thing that it can tell us is there some type of hematoma? Like, is there an intramural hematoma present as well? So this is kind of like the gold standard of what you should go by to be able to diagnose someone with an aortic dissection. Let's go ahead and take a look at some images of what these things actually look like. We finished all of our causes, etiology, pathophysiology, diagnostics, clinical features tied in with the pathophys, and the diagnostics. Now the last thing is the treatment. How do we treat these patients? They're very sick, they're very problematic, they could decompensate at any moment. What do we do, ninja nerds? First thing we have to determine is what type of dissection they have, because that determines their therapeutic management. So let's take a brief talk about that. So there's two types. Now there's two systems, the classification systems that we utilize. There's the DeBakey system, 1, 2, 3. That's not commonly utilized anymore. Some institutions still utilize it, but the preferred classification that you guys need to know for your exam, and it's starting to be more incorporated into institutions, is the Stanford classification A and B. So let's utilize those particularly. So we have what's called a Stanford A classification of aortic dissection, and then you have a Stanford B type of aortic dissection, okay? So Stanford A, I'm gonna make it real easy for you guys. Stanford A involves the ascending aorta. If it involves the ascending aorta, doesn't matter if it's going beyond, like if it starts with the ascending aorta and it goes all the way down the aorta. If it involves the ascending aorta, it's a type A. Stanford A, aortic dissection. So A, so it's involving the ascending. Here, I'm going to put A for the A here. Ascending aorta is involved. These are scary emergencies, need surgical intervention. So for these, what would you give them? these would get surgery. Okay? These are scary. The ascending aorta, if it's in the mediastinum, you bleed, you rupture, terrible complications can ensue. So this one needs immediate intervention. Now, Stanford B is, I like to remember, it's beyond the left subclavian artery. But to be more specific, if it's beyond the left subclavian artery, it has to involve the descending aorta. So again, since it's beyond the left subclavian artery, we kind of say that's the descending aorta, right? So that is our descending aorta, okay? Now, with Stanford B, these ones you can give medical therapy. Okay, and we'll talk about what that medical therapy is. But you may need surgical intervention. If the dissection is continuing to propagate, it's getting worse, so you're getting a continuous expansion of the false lumen. You're getting a really large intramural hematoma. They rupture and they become hypotensive. The medical therapy has failed in some kind of way. Anything like that could potentially push a patient to needing to get a surgery. So it's medical therapy first and plus or minus surgery if they develop issues where the medical therapy is failing or they're just becoming more hemodynamically unstable. Okay? Now that we know the two types, we can go into the surgical therapy and what it involves. It's not really that crazy. All I want you guys to know is there's two options. We can open them up and take, for example, here, you see how we have this intimal flap here, and then you have the dissection that's actually creating like a little hematoma, and it's dissecting either distally or it's dissecting proximally from that actual intimal flap. All we can do is we can actually cut out that disease portion and then put in what's called a polyester graft. A polyester graft. And this is an open surgery. So this is an open heart type of surgery. There is other options where you don't have to open them up, okay? Generally, this next one is not actually like approved to do anything with the ascending aorta. It's particularly a little bit more of the descending aorta, so more likely to involve your type B dissections that haven't responded well to the medical therapies. But this one, you could take, for example, here's where the intimal flap is, here's where the dissection is, creating your false lumen and your hematoma that's forming here. What you could do is you could actually place in a stent. So you actually do what's called an endovascular stent placement. And that stent allows for you to be able to allow for blood to continue to flow through the true lumen via the stent and not outwards into that false lumen. So that's another option that you can explore. So again, two options for surgical therapy: polyester graft, particularly this is for your type A's. Okay, and then you can do an endovascular stent. This is usually your type B's that haven't responded to medical therapy, and they unfortunately have continued to worsen and they need an endovascular stent. Now let's talk about the medical therapies. All right, medical therapy, there's two scenarios here. We have to target something. In the worst case scenario, the scary one, the one that will make you pucker your sphincter a little bit, is the hypotensive patient. If you have a patient who has an aortic dissection and they are hypotensive, this will kind of make you a little bit nervous. So there's hypotensive therapy for those that have aortic dissection, and guess what? The reason why they probably are hypotensive is one of two reasons. They ruptured and they're starting to bleed from that dissection that ruptured. Second is they have a cardiac tamponade. Third, they have severe aortic insufficiency or regurgitation that's causing a decompensated heart failure of some kind. So those are things to think about, and we'll write that down here. What are the three things to think about? But if someone's hypotensive, there's three therapies that you want to employ for this person. First thing is you want to give them fluids. So IV fluids is going to be the first thing. If you flood them with IV fluids, what is the whole point of that? IV fluids is going to increase their blood volume. If you increase their blood volume, their effective arterial blood volume, you should be able to get their blood pressure up. The question is what type of blood pressure are you aiming for? You have to have a goal. You want to aim for a MAP, a mean arterial pressure, which tells you your perfusion to organs, of greater than or equal to 70 millimeters of mercury. You have to have a goal of what you're trying to aim for. In this case, using fluids, good amounts of it, to be able to target a blood pressure, particularly MAP, of greater than or equal to 70. Let's say that you've given them fluids. It isn't working. You need to give them something else. I need something to squeeze the vessel. So then I can do something to push in drugs that maybe will bind onto the alpha-1 receptors and clamp down on these vessels, make them squeeze a little bit. And if I squeeze them, I can increase my systemic vascular resistance, and that can increase my blood pressure. What would be drugs like this? You can give vasopressors, and there's so many different options here, but vasopressors that you could be particularly giving is something like norepinephrine, which is one option. Another one is you can give another drug called phenylephrine. Phenylephrine is a pure alpha-1 vasoconstrictor as well, okay? What if the person's bleeding? What if they ruptured and they're bleeding and they're losing blood into their abdomen, or they're losing blood from somewhere else, and that's also causing them to have a low blood pressure? You can give them blood. So maybe you need to give them blood. And if you give them actual blood, you can increase their blood volume and therefore hopefully increase their blood pressure, perfusing the organs, okay? So that is another thing to think about is, again, do they need fluids to augment their blood pressure? Do they need pressors to augment their blood pressure? Or do they need blood products because they're losing blood to augment their blood pressure? The next thing that you have to remember, though, is what is the reason that they're having this hypotension. You have to evaluate for three particular things. Evaluate three things. Okay? What are those three things? Did they rupture? Do they have cardiac tamponade? And do they have aortic insufficiency that's causing them to develop acute heart failure? If they have a rupture, you have to repair that. Blood's not going to last long. Fluids and pressors aren't going to last long. Cardiac tamponade, you can quick that. Stick a needle into the actual pericardial cavity, drain it out. Aortic insufficiency, you need to repair the valve. So things like that is things that you have to figure out why they're hypotensive and fix that. And that can help to buy you some time. Unless this isn't working, you need to get them to surgery, okay? The other option, though, this is where, again, it's very important. You have to remember this one, guys. This is like the bread and butter for your exams, is hypertensive treatment. So hypertensive treatment. This is what you guys are going to get tested on for your exam, no doubt about it. So whenever you have someone who has aortic dissection, they most likely are having a dissection because their blood pressure is high. And their blood pressure is going to continue to be high. So what do you have to do to prevent the continual propagation, worsening of the dissection, prevent the risk of them rupturing or anything of that nature? Get their blood pressure low, man. Drop the blood pressure a little bit. So that's what you have to do. But you have to have a target. You can't just tank them and say, okay, let's have them at 40/0. No, I have to have a goal. My goal is I want to give them a systolic blood pressure anywhere from 100 to 120 millimeters of mercury. But also, what's another thing that determines your cardiac output? Not just contractility and squeeze, but also it's your heart rate. I don't want them to have a really, really fast heart rate. So I also want to target a heart rate less than 60 beats per minute. Okay, I don't want it to go too low, but I'd like it to be somewhere around 60 beats per minute ideally. So what can I use for that? The first thing, and it's very particular on your exams, the first thing that you do, so let's actually write that down first, is you have to give them a beta blocker. So the first treatment is you give them a drug called a beta blocker. Now these beta blockers are very specific. One of them is called esmolol. The other one is called labetalol. And these have a dual function. They're not only beta blockers, but they have a little bit of alpha blocker activity as well. So what would you get out of this? If our goal is to lower blood pressure and lower heart rate, what will the beta blocker do? The beta blocker will bind onto the SA node, the AV node, and lower what? Lower your heart rate. So as an effect here, from inhibiting the SA node, inhibiting the AV node, you're effectively going to lower the heart rate. And by binding onto the alpha-1 receptors on the blood vessels, it's going to do what? It's going to inhibit the vasoconstriction mechanism. If they're blocking, so they're an alpha-1 here, let's put alpha-1 blocker, they're going to block this alpha-1 receptors, they're going to decrease the vasoconstriction, and they're going to result in vasodilation, lowering the systemic vascular resistance and lowering the blood pressure. That's pretty good, right? So these are the two drugs that you would give. The reason you give them first is because you have to give a second drug that can really dilate your vessels really hard. If you dilate your vessels, what does it do? Lowers your blood pressure. What's the problem with low blood pressure? You know, in our mechanisms, the regulation, low blood pressure will trigger particularly your brainstem, your cardiac acceleratory center, to say, hey, blood pressure is getting lower. Let's try to cause the heart rate to increase and the contractility to increase. And then your heart rate will go up as a result of giving a vasodilator only. So don't give this next drug first. You have to give this first. Why? Because son of a gun, dang marker, this will prevent what's called reflex tachycardia. Okay, that's why you give this one first, preventing reflex tachycardia. The second drug that you give is a vasodilator. So we're going to give a drug called a vasodilator after we've prevented them from having reflex tach. We kind of got a prophylactic measure on. We're going to give a vasodilator. And the vasodilator of choice in this scenario is what's called sodium nitroprusside. So we give something called sodium nitroprusside. And basically what this is going to do, this sodium nitroprusside, is it's going to act in a way that it's going to also cause vasodilation. It's going to decrease your systemic vascular resistance, and it's going to decrease your blood pressure. And that's going to help to keep the blood pressure in the lower range of 100 to 120. And then you get the beta blockers to also help with that process. But because vasodilators can cause, what's the problem with these? Cause reflex tachycardia. You have a drug that you already onboarded to prevent the reflex tachycardia, as well as give a little bit of vasodilation via the beta blockers. That covers aortic dissection. All right, Ninja Nerds, in this monster of a topic, we talk about aortic dissection. I hope it made sense. I hope that you guys enjoyed it. As always, Ninja Nerds, until next time.